Hey, this is Doug Fields, CEO of the Institute for Healthcare Consumerism, along with my co-host, Brent Macy, Managing Director. And welcome back to the segment of Healthcare Consumerism Radio, where the discussion continues around innovation, and specifically on this segment, talks about big data, something that may confuse a lot of people out there, and something that we hope Dr. Graham Hughes, Chief Medical Officer with the Center for Health Analytics and Insights, a part of SAS Institute, is here to open our eyes to. Dr. Graham, welcome.
Well, thank you. Thanks for having me.
Yeah, good to have you on the program today. Tell us a little bit about SAS Institute and the Center for Health Analytics and Insights, and then we'll get into the discussion on big data.
Okay, yeah. SAS Institute is the largest global provider of analytic tools and services in the world. We have the premier suite of advanced analytic applications that serve multiple different industries, and so whether it's financial markets in monitoring liquidity or market basket and portfolio risk, to bioterrorism threats and anticipating risk associated with those types of things, pricing optimization, consumer engagement, and so forth, forecasting the weather. We have a healthcare division within SAS, which is focused on payer, provider, employers, big pharma, and value-added providers and intermediaries who need to manipulate data to try and improve healthcare from their particular perspective. I'm a physician, and I lead a group which is a research and innovation group within our health and life sciences team, looking for new ways that big data can be applied across the industry to improve patient care and to help us better understand how we can improve outcomes while controlling costs.
Yeah, tell us specifically what you're doing around patient engagement for population health. Talk a little bit more about that, please.
Yeah, that's a really huge topic, and I think one that's really not particularly well understood. But we think about patient engagement and population health. There's a lot that I think healthcare organizations can learn from other industries. Other industries have been trying to figure out for years how to use data that they have on their consumers and their customers to make the interactions more sticky, whether that's on the web or whether it's through other types of outreach approaches. And so what we've seen is that healthcare has been very slow to pick up on these types of proven techniques, and whether that's using what I think sometimes is being called the data exhaust that we all leave behind, the digital trail that you and I leave, and not only through electronic health records and claims data, and more recently things like information about your genomic predisposition, but other stuff that is more like big data that is outside of you and that surrounds you, which is, sociodemographic, behavioral data, geodata, air quality, distance to health center. Those types of data are now starting to become aggregated in a secure fashion to better understand your likely risk, both as an individual as well as groups of individuals like diabetic patients or patients with congestive heart failure, and better anticipating what the needs of those patients might be over the next 6 months to 12 months, rather than just looking at the performance in the past. So a lot of this is then understanding the population, understanding their risk, but also understanding what might be the right way to engage in them, not just in this episodic face-to-face type of model that we're so familiar with, but more in a 24/7 type model that has been that we've all grown used to with other consumer-based organizations, whether it be through web interaction or video conferencing or other types of outreach mechanisms. So different outreach mechanisms and interventions need to be applied for different types of consumers within the healthcare ecosystem. And whichever angle you're coming at it, big data is at the heart of the way that you need to understand both risk as well as prioritization, preference for engagement, and then to be able to measure the engagement of the individual and then what it is that you might need to do next to respond to that.
So that's where healthcare can really learn from some of the other industries when it comes to really engaging consumers.
Exactly. We've had instances over the years where large retail organizations have made a science out of this, and whether it's organizations like Walmart or Target that actually utilize all of the information that they have to provide you with coupons and buying recommendations as soon as you check out of the store based upon your buying patterns and the other information that they may know about you. But the idea is to target things that are meaningful for you, not something that's intrusive or this type of big brother approach, but more to be, how do we optimize not only the interaction with the individual customer and groups of customers, but how do we better optimize things like pricing and store placement. So these things that have been done for years in other industries, including things like page-level optimization. So you're probably very familiar that when you go to a particular website, your experience on that website for most of the advanced interactions is very different than my interaction would be, because they're highly personalized, and we've missed that level of personalization in healthcare. And that personalization is typically driven by advanced analytical applications like SAS that are computing hundreds of millions of data points at scale to try and make sure that we can better anticipate what might be the right thing for you next. And in this case, it might be spotting patterns like the fact that you need a blood test or a checkup, or that it might be to try and encourage you to more actively engage in wellness campaigns. And there are different things that will work for different populations based upon whether you're a person that is highly digitally engaged or someone who isn't. And those are the types of techniques that have been used time and time again, but have just not been applied very effectively yet in healthcare.
Dr. Hughes, this is Brent. Why do you think that the healthcare system, or healthcare in general, has been so slow to adopt these types of tools that you're speaking to?
Well, it's interesting. I think it's been there hasn't really been that much of an incentive to engage customers. In other words, if you get sick, you go and see your doctor, and in general, there's a demand there that you don't need to solicit. And if you're a physician or a physician group, and you're incented primarily on just dealing with as much volume as you can, and that the more patients you see, the more money you make, then the incentives are all skewed wrongly, and it's sort of almost 360 degrees or 180 degrees, I guess I could say, away from a typical type of consumer-based interaction where you're looking to try and create stickiness, and your competition, instead of just being purely on adverse experiences, which is essentially when people get sick, is that by incenting performance-based contracting and value-based payment models, suddenly you start to get alignment of the incentives to try and do what patients really want, which is to stay healthy and keep out of hospital. And of course, to this point, where the money had gone was in making sure that patients take more medications and have more procedures. So I think that we're starting to create an ecosystem where it's in everyone's interest to engage the patient more actively, not just to maximize the amount of money that can be withdrawn from a particular population, but to optimize wellness and healthcare, which is all about having to understand risk and get ahead of the game, which pretty much every industry has to understand. Risk has just not been something that healthcare provider organizations have cared that much about from a population health management perspective, because they were not incented to do it. So a lot of the healthcare reform focus on transitioning to value-based payment models and increasing risk being pushed to the provider, I think starts to put the emphasis where it's needed, which is, at the point of decision. And so we're now getting to a stage where it's rather like the family physician of the past. They used to know you, your family, your brothers, sisters, your parents. They may even have brought you into the world, and they see you down at the corner store and at the local church, and they understand you as an individual. Those days have typically gone, but now with some of these digital tools and techniques is that we can proxy for that by better understanding you as an individual and the motivations that you have, so that recommendations can be much more highly tailored and personalized.
Yeah, it's interesting that, to your point, I mean, patients haven't been treated as consumers, and patients haven't understood how to act as consumers. And now we're in that age where, all of that is taking place. We got about 2 minutes to go, Graham, and I want to give you, give us kind of a look ahead to 2020. What this experience might look like, if you can do that in a minute or two.
Okay, yeah. Well, it's always risky looking into the crystal ball.
Yeah.
You'll look back on this in 10 years or 5 years and say, what were they thinking? But I think that what we're going to see if we're in 2020 is not so much that all of the technology has dramatically changed, but what we will do is we're going to use the data we have today and the technology that exists today much more effectively. I think we're just on the early stages of learning how to integrate the data, clean the data up, make it available. So I imagine a situation which is much more focused on the patient as consumer and the individual, where instead of the physician, today the physician, the health plan, the employer is getting all of the information and being enabled as a sort of, in a patriarchal type sense to assist and provide guidance to the patient as some notional sort of external third party. Is that I think that what's going to happen is that all of these tools will start to be focused as capability that is empowering for us, for you and for me. And what I mean by that is that you will be the first to know rather than the last to know, and that you would be in control through a series of localized health applications, whether on your mobile device, whether linked to sensor technology that you're wearing, or whether it be to, other wearable technologies and computers, is that the idea is that you would be notified ahead of anyone else based on your preferences, your security, what you want to share, is that they would be giving you health coaching guidance and advice, and you would be able to link in or connect to healthcare providers and other caregivers using the big data that you're now utilizing to power the transformation in healthcare. So I think we're really going to see a shift away from the healthcare provider or the health plan and the employer as being the owner and the manager of those data, back to the patient having control of the big data assets and how they're used.
All right, hey, Dr. Hughes, we're coming up to a hard stop here, and really, really appreciate your insight and the discussion with you today. And we at the Institute look forward to continuing that with you. You have a great weekend, and I really appreciate your time.
Thank you very much.
And to our audience, we'll see you next week on Healthcare Consumerism Radio.